We will have, I think, an interesting topic this morning, which is mental health. And to cover this topic, I invited, not as usual, 2 persons, but 3. And I would like to apologize for a problem I realized during these sessions. The problem was the insufficient balance in terms of gender here. So I am very happy that at least in the final session, we have also a woman speaking to the audience. And I commit Fabrizio for next year to do better than I did this year. Okay, a few weeks ago, one of the most influential labor economists in the UK, Lord Richard Layard, jointly with a psychologist from Oxford University, published a new book titled Thrive, The Power of Evidence-Based Psychological Therapies. Layard has been one of the first economists worldwide who started in economics a new promising field of research called nowadays happiness economics. One of his favorite theses and the slogan used to be the following one: few factors are causing such a great waste of happiness and human flourishing as mental illness. According to Layard's new book, mental ill health causes more of the suffering in our society than physical illness, poverty, or unemployment. In the UK, around 7 million people are afflicted by a mental health disorder, but only 15% of them are being treated. Poor mental health has not only a terrible impact in terms of wasted human flourishing and happiness, but it represents also a major financial challenge for societies. In the UK, mental health problems directly accounts for a loss of 4% of GDP. On top of this, there is another 2% of crime committed by mentally ill people and 2% of additional cost of above average physical care to people with mental disorders. And in Switzerland, the situation seems not to be different. According to a recent OECD report, mental ill health represents a high cost for Swiss society, accounting for roughly 3.2% of GDP. And a second OECD report, published in July, makes a strong argument for investing in improved data on cost, outcomes, and quality of mental treatment. At the same time, the report recognizes that what blocks government doing the right things is a combination of a lack of resources and misplaced priorities. And finally, let me remind the valuable contribution given by the Italian psychologist Franco Basaglia, who challenged the traditional approach of psychiatry and brought segregated mental ill people back into society by fostering their economic and social integration through, for instance, in Italy, social cooperatives. So the current session, which is the last one of the series, so tomorrow you can sleep a bit longer, or you prepare yourself for the final exam, or you can buy something in the city, I don't know. But today we try to disentangle the challenges of poor mental health trends and to debate the controversies of public mental health policies. We do that with the help of our 3 distinguished speakers. First of all, Emiliano Albanese is a public health physician and epidemiologist. He is a SSPH plus assistant professor of public mental health at the University of Geneva and the head of the newborn division of public mental health of the Institute of Global Mental Health in the Geneva School of Medicine. Then we have Martin Knapp. He's an economist, professor of social policy at the London School of Economics and Political Sciences, director of the School of Social Care Research funded by the National Institute of Health Research. And finally, Meichun Mohler-Kuo, who was trained as a social and psychiatric epidemiologist at the Harvard School of Public Health, is now the head of the Mental Health and Social Epidemiology Unit at the Institute of Social and Preventive Medicine at the University of Zurich. So we tried to speak 1 hour and to have 30 minutes for discussion. So Emiliano, the floor is yours.
Good morning. Thank you very much, Luca, SSPH Plus, everybody here in Lugano for the invitation. This is second here. It's a pleasure and an honor. I will not spend too much time in the introduction because Luca was really helpful with that. And I'll just tell you that my presentation is also giving some background of value for the next two presentations. Although I'll be a little bit faster here to focus on the issues on global mental health, pending controversies. My acknowledgement goes to Benedetto Saraceno, who's a friend and my mentor, to whom my work and this presentation is inspired. So very quickly, a little bit of history. Global mental health was essentially the health, the level of psychological distress in population up until a few years ago. The revolution essentially started with WHO publications and two important Lancet series of global mental health that redefined this concept overall. So now this is defined as the field of action, which is essentially expanding, is evidence-based as an approach. So here are definitions of public mental health is, as you can recognize, the definition is, you're very familiar with it, applied to mental disorders. There is no agreement about a definition on global mental health. It's a movement, it's an effort, very much collective, to try and readdress resources to those who are most in need. This is a slogan, quite successful and powerful, but what is the substance to this slogan? Well, on the one hand, as Luca anticipated, the burden of these diseases. This is just one of the possible very many figures of the burden, according to the global burden of disease of neurological and mental disorders. And as you can see, they are responsible for a lot of the disability and mortality amongst other chronic diseases and infectious diseases as well. But the second aspect which provides substance to the slogan of no health without mental health is the relationship of mental health with physical health. So there are, for example, cardiovascular risk factors at the top, or lifestyles that are related to mental disorders, and these increase chronic diseases and also the likelihood of getting infectious diseases. All these combinations provide a worse scenario for prognosis. In fact, the relationship may also work in the opposite direction, and you see here that chronic diseases may be extremely distressful, the care, and there might be iatrogenic effects, that is, treating chronic diseases may have causes on the brain, and there may be common pathways and causes. So you see that it reverts back. So it's not a simple association, it's quite complicated, but it's very substantial. Another important argument in global mental health is, as Luca also said about the UK, the fact that most who are in need with mental disorders, also serious, do not receive any treatment. This is just one of the very many papers illustrating the case on an evidence-based level published in the New England Journal of Medicine a few years ago. So when we talk about the mental health gap, in fact, we should remind to ourselves that we talk about the mental health global action program. It's not just a gap, it's what we have to do to bridge and fill this existing gap. And as you know, in public health, there are several components that apply also to public mental health. So epidemiology is, as usual, the cornerstone of our action, but also health promotion and prevention, system and service, and important components of evaluation of what we do and of the functioning of these services. We claim that we must use an evidence-based approach. You see here that these evidence-based contributes to, first of all, describe the size of this phenomenon for the burden, but also the effectiveness and cost-effectiveness, as Martin will tell us, of interventions that we have. These are the publications that address international or global health in general. And you see that infectious diseases are leading, but the rise is occurring also for chronic disease and mental disorders. So the trend is positive, but still lots of work to do. Okay, let me come to the second half of my presentation, which will be a little bit more interactive. And I'll try and make a statement and try and see whether this statement can be disproved. I'll start from the very beginning. The classification of mental disorders is clearly not a precise science. This has been a long debate in psychiatry, and not only in psychiatry. And the two main classification systems are the very famous DSM, now in its 5th edition, though we should say 5 for some reason, which is the Diagnostic and Statistical Manual and is related to the American Psychiatric Association. But the other one, the International Classification of Disease, is another instrument which is widely used. I want to stress here the importance of the differences between the two classification systems. DSM insists on validity, and validity is essentially the possibility of distinguishing a disorder, a mental disorder, a diagnosis in a final instance from normality, and from other disorders. Whereas the ICD insists on clinical utility. That is, that when a diagnosis is made, this provides an advantage to the patient, but also to clinicians and health workers in general. However, the actual evidence base of the DSM has been criticized widely, but also by this person here, who's actually happened to be the director of the National Institute of Mental Health in the United States. So it's a big argument also within the field of psychiatry. And possibly ICD is failing somewhat in having a real clinical utility because the most common coding is in fact not elsewhere classified syndrome, which is not very useful in the end. What is the relevance for global mental health? Well, the scaling up idea that is improving and increasing services and treatment response for those who have mental disorders may be too fast and too furious, because essentially the reduction of a very complicated definition of mental disorders to simple departure from a biological normality, if it exists, may be exported to globally and to developing countries particularly, and this represents clearly a risk. Stigma and discrimination are central in the public health field and in global health particularly. These are the definitions, and you can really understand that though stigma is an attitude, discrimination is the consequence of stigma. So these provide an impact, but they are extremely linked to one another. Professor Grant Thornycroft is the world's expert in stigma. He explained very well all the mechanisms and what we can do to reduce it and reduce discrimination and the impact of stigma. However, this figure is really the figure that we use for MH-GAP and represents a mental health patient who is coming out from neglect and is getting back into society. So what is the problem with stigma and discrimination that we have? Is the fact that we have to recognize that in most cases, both stigma and discriminations may be the consequences of the current mental health services because of the experiences that users, patients, but also their family and society at large have in interacting with these services. So the impact is quite obvious, and it's the fact that anti-stigma campaigns that have been conceived without considering this aspect may not only fail, but it may increase stigma itself and therefore a barrier for the development of global mental health. Named barriers. Well, there are very many, and one of the papers of the Lancet series of global mental health, the first one, did a great job in illustrating these barriers. We also know from other experiences in global health that we can do a lot to tackle these barriers. This is the example of HIV/AIDS that for stigma and discrimination particularly is very similar to the problems that we have in mental health. The key characteristics of this movement for the success that they had were the fact that the movement was very much united and that they were giving out messages and claims that were absolutely clear and understandable by very many. What is the situation for us? That global mental health is extremely heterogeneous and sometimes contradictory. Some people ask for more hospital beds, others less. Some people want more psychosocial interventions, others insist on the importance of having more drugs. And ultimately, the debate about psychiatry and anti-psychiatry with reciprocal accusations of being too much linked to the pharmaceutical industry on the one end and be somewhat disorganized and irrational movements. So you see that these tensions provide an outside message that it's certainly not helping the cause of global mental health. So politicians and policymakers either don't understand or pretend that they don't, and they just pass on to the next issue on the agenda and may talk only to experts instead to academics that have provided evidence base. Okay, now more on the organization of health services for mental health. There is not much of a great difference in the very general structure of these services. So there are the typical 3 levels, and you can recognize in the first level the primary health care level, which is established in other fields of public health. And the second level, which is the crucial one, is specialized, we will see in a minute, but it's clearly not an hospital, which is the third level of the health system, to put it simple. However, there are serious unresolved issues, as we will see in a minute, both with the first 2 levels and the hospital and the process of the institutionalization of patients, so letting them out of hospitals, whether they are psychiatric hospitals or general hospitals. So the idea is that the emphasis that the global mental health movement is these days and the past few years putting on primary health care as the perfect solution for all our problems is a wrong message because it cannot work in isolation. Let's see why. If you essentially add mental health components and responsibilities in primary health care that were conceived and designed for other reasons, other health conditions, you increase the workload. Also, you cannot expect to have great competence and appropriateness of use of drugs if they work not in any ideal situation. And finally, which is very important from our health service perspective, is the idea that this primary health care level does not communicate at all or enough with the other 2 levels, which is as important. However, there are very nice positive examples, some of which are from developing countries. The example of Iran, where the task shifting, so the idea that community health workers can collaborate with the primary health care, so the first level, to regulate access through triage or screening at population, but also take care of long-term care of people with mental disorders, which is as important. So once they are back in the community, they need to be followed up actively, and cannot be the doctor, cannot be the health workers in the few clinics. The example of Burundi is particularly interesting, we believe, because it's an NGO that's decided to train primary school teachers with some competence in mental disorders. It could be as simple as that. And they also gave them motorcycles to reach the most remote areas of the country. And this seems to work. However, we must say that the evidence base and the methods used to determine whether these examples, which are really fascinating, could really be scaled up because they are cost effective, not just efficacious, is still lacking. This is also why primary health care is still nowadays a place where we tend to give a lot of drugs to a lot of people who may not even need them. There is another serious issues with the second level because it's clear that if it's clear that the first level cannot be enough for the hospital, it's less clear that the idea that those who are in the second level are in fact highly specialized people, and they collaborate strictly with the first level, and they are the only way of access to hospital, or they should be so. We hear very often that the lack of resources is the reason why there is not enough second level in most countries, including high-income countries. However, the reality is a little bit more complicated. We'd say that there is, what the resources are present, a lot of redundancies in the type of second level services, and also that the second level is disconnected, both from the first and the third level. So it's essentially pretty useless in that form, and it clearly increases costs. So the impact is quite obvious. The idea is that positive examples, there are few, like the Centers for Psychosocial Care, developed and improved in Brazil, as we will see in numbers in a few slides, must be essentially studied to be scaled up globally. Okay, let's come to a very important topic in public mental health and psychiatry generally, the argument of the institutionalization, which clearly is related to the third level of psychiatric hospitals. So this is not a new idea, and Luca mentioned this. So this is an Italian psychiatrist with the collaboration of all population, made a very interesting revolution in obtaining a law which was mandating the closure of psychiatric hospitals in Italy in a given time, but it was also suggesting and detailing very much how this should have been done. Brazil is nowadays a very good example of how this can be done seriously on a national scale, and it's a very big country. You see here the reductions in the number, these are in thousands, okay? It gives an idea of how many beds they have, psychiatric beds they have throughout the country. From 2001 to 2011, they went down of almost 40%. But at the same time, which is very important, they had a significant increment, very significant increment, in the centers for psychosocial care, second level. If you don't do the two things at the same time, they won't work. However, there are so many howevers about the institutionalization, but the first one is the fact that there are far too many psychiatric beds, both in psychiatric hospitals and in general hospitals. You see that there are differences across European countries. This is the mean. Germany is right at the top. And it's not just the absolute numbers that is a concern. This is the trend of a change across 10 years. And you do see that it's not enough. Some numbers are not even negatives. The number of psychiatric beds is therefore decreasing too slowly, but positive examples exist, as we have seen. However, the problem is that these hospitals, in most cases, provide mainly a function of sedation, of containment of people with mental disorders. So they fail entirely the purpose of being a highly specialized third-level environment, as you can think, for example, for surgery, where you need to have such a place. But hospitals are also responsible to perpetuate and give a message that increases stigma and discrimination, and where violation of human rights very often occur. In fact, Brazil is the only country in the world that clearly states the institutionalization in their national plan. So it's clear that we have to believe and think that these positive examples must be publicized and scale it up, not just the primary health level, but these general examples of how things can be done. And to go to the conclusion of my talk, the moral case of public mental health was defined a few years ago very clearly in this important editorial. These are the three, I would say, most important moral aspects in global mental health, and is essentially the assemble of the arguments that the evidence base is not enough. These are the arguments for a moral case that should actually help us to improve mental health interventions and services. We've seen no health without mental health and explaining it, that mental disorders are treatable, so that a lot can be done. This is evidence-based. So we know that there are treatments out there, which are not necessarily only drugs. And we know that these can be cost-effective and made available at very little out-of-pocket price also in settings that have very little resources through generic versions of drugs. Examples from other global health actions. And so on. The brain drain should be reverted, that is, experts that come from developing countries and find better jobs in developed countries, essentially reduce even further the workforce in these settings. This needs to be reverted. So we should send more people there to help them. And of course, the key aspects of human rights violations, which may represent an opportunity if they lead to legislation. And this is a general consideration about the fact that the globalization has a huge impact on mental health, but might also be an opportunity because developing countries are increasing their wealth, and some of that should be dedicated to the improvement of health service. Let me just draw your attention to the fact that they talk about evidence that goes beyond the evidence base, and this is an important argument in public mental health. So we want to be evidence-based, but in the lack of evidence base, we do action because there are these moral arguments to move on. So the problem with this is that essentially psychiatrists mainly are opposing a strenuous resistance to this big change, and it's not new. And this is, well, there are several cultural explanations for this, possibly because treatments is the key identitary aspect for psychiatrists. There have been several discussions about that. But the idea is also that, as you've seen yesterday, conflict of interest are extremely important in psychiatry as in other branches of medicine. So it's not clear whether the intentions are positive or not. According to ProPublica, which is an independent organization, psychiatrists were at the very top of those who received money from pharmaceutical companies amongst all medical specialties. So the impact is clearly the fact that the real gap is not between only needs of those with mental disorders and whether they receive treatments or not, but there's also another gap, which is the gap between treatment and health services that, as we have seen, often conflict and don't allow the second to flourish. This is my last slide, and I think is the reason of hope that I want to give you, is the fact that activists like David Oakes, who's world famous, but also in the UK particularly, new initiatives are extremely promising. This is the first appointed research-led professor at the Institute of Psychiatry in London. She is a user. David Oakes defining himself as a survivor, not only a user of psychiatric hospitals. So they tell us how essentially research can be helped by users in many ways. But the reality is that they are still a minority among users themselves, for clear reasons you can understand, but also researchers and academics that believe that users are central in research and also in public mental health are too few, as well as health workers and policymakers. However, users have helped enormously in the development of the Convention of the Rights of People with Disability, which is one of the strongest international documents we have to protect patients overall. So let me conclude with this, that I believe that global mental health will gain a lot by an active involvement of users at all levels, and that services will be developed in a more sustainable but also human way, thanks to them. Thank you very much for your attention.
Right, sorry about that little episode. So thank you very much, Emiliano. Emiliano covered a huge amount in a very short space of time, very impressive. And what I want to do is just to respond quite briefly, focusing on the economic case. I'm going to move between low-income country context and high-income country context to use some evidence. I'm just very quickly going to go through some of the arguments that I think can be made for better attention to mental health from that economic perspective. So the answer to my question, is there an economic case, is yes, probably. I think in some countries there's a very clear case. In other contexts, I think as Emiliano was saying, the translation of evidence across is more challenging. So I'm going to argue just very briefly on the grounds of disease burden, and particularly its distribution, which I'll show you in a moment, on the way in which healthcare resources are used, the efficiency of use, on contributions to other sectors, on contributions to economic growth, on the grounds of equity and public attitude. So actually blending very well. Emiliano and I had a talk about this yesterday and the day before, but I didn't see his slides until this morning, and I was delighted to see there's not too many conflicts, so that's okay. Now, I'm going to show you two tables that are taken from this little document from the World Health Organization, written by Dan Chisholm, who's an economist based there. It's a very short little document, maybe 10 pages or so, trying to summarize what the economic arguments are for investing in mental health. It's a very useful document. So first of all, this table, which is one I had to re-find in my slides just now, just summarizes what Dan has set out as 6, what he says, perspectives or value bases that we would maybe want to think about when deciding on what attention we pay to health, including mental health. So he distinguishes public health, economic welfare, economic growth, equity, socio-cultural issues, and political influence. So just briefly to explain what they mean, because I want to use those to then illustrate what the case might be for and against looking at mental health, or particularly prioritizing mental health. So public health, of course, is promoting, preventing, maintaining health, and the issues in the right-hand column there that we need to consider as researchers, as activists, as decision makers, would be this burden of disease and how much is attributable to health or particular health conditions, how much can be averted. The second perspective is economic welfare, and that's clearly maximising individual well-being, taking account of the resources are there, and we know that health is a key component. The third one is economic growth. So how do we support economies, or how do economies support themselves to grow, to improve productivity, to improve standard of living? Well, again, health is a major contributor to economic growth. And mental health I'll show you in a moment. Equity, how do we promote fairness in the population? Well, we know that health and health issues are not equally distributed across the population. So health and health discussions contribute to those discussions of equity. The fifth one is socio-cultural influence. We need to be aware of individual beliefs and attitudes and cultures, and we know that that will play out in different ways in the health context, particularly around perceptions of illness, and Emiliano mentioned the very important issue of stigma in mental health. And then political influence is about setting the structure for these things to happen, intervening where necessary in markets, and we know that in health, market failure is endemic. So I'll use those perspectives and just reflect on the evidence for and against mental health. So the first one, public health. We know that mental health problems are a major cause of disease burden. I'll show you some figures in a moment. And there are strategies to reduce that burden. That's the argument for mental health. The argument against is, well, hang on a moment, mental health problems are not the only problem out there. There's lots of other health conditions as well. So what do we know about mental health? Two slides very quickly. One is, this is from Dan Chisholm's report, 25% of years live with disability and over 10% of the total burden of disease attributable to mental health. So we know there's a big impact. But the thing that particularly interests me is the distribution of that impact by age. Now this slide, and people on my course will have seen this yesterday, but this slide is from the Global Burden of Disease study, which reported a whole set of new results just recently. These are figures for the UK, and I apologise for focusing on the UK. These are figures for the UK, and they show you what different diseases or illness groups have contributed to this burden at different age groups. So, what you can see, the red bit in the middle, the large red part, let me just go to, so I put in the circle there the two I'm most interested in. One is this large red sector in the middle of that slide, and see how that starts very, very small in early years, of course, and then grows to be particularly high in late adolescence and early adulthood. And then it seems to decline, but actually when we get to old age, we have the major problem of dementia, and that's the sort of pale pink colour that's very important in the right-hand column. Now, what I've put in there is just shown you that particular age span. Look at the contribution that mental disorders make to total disease burden, shall we say, or disability burden, in late adolescence and early adulthood. That is exactly the time that individuals are investing in their human capital that will probably determine the rest of their lives. So if you're mentally ill and you can't complete your education, or you can't get into a job, or you can't form a personal relationship very stably, that's going to have an impact for the rest of your life, or could do. So the disease burden is particularly pernicious, I think, in mental health because of the time in which it happens, or begins to happen in a big way in the life course. Second argument is about economic welfare. Mental and physical health are core elements of individual welfare, mental health particularly, and Luca mentioned the happiness components, for example. But of course, there are many other things in life that influence economic welfare, such as your income and your consumption patterns and so on. So what's the case for mental health? Well, as Luca showed, there's lots of contributions negatively to happiness. We know, as Emiliano was saying, that poor mental health can contribute to poor physical health, and vice versa. We know that treating the mental health needs of people with physical health conditions can be enormously influential. There was an article I mentioned to my group yesterday on the BBC website yesterday. A paper came out in The Lancet yesterday showing a very high proportion of cancer patients who have depression, and the very low proportion of cancer patients with depression who actually get it treated. So we could do something about the quality of life of people with other conditions by paying attention to their mental health. And then the final bullet is, well, there are interventions that are effective and cost-effective. Unfortunately, most of the evidence in support of those is in high-income country contexts. Now, in the low-income country context, let me just say two things very quickly. One is, this is a study conducted by one of my PhD students. It's going to be coming out subject to final revision in a journal later this year. This is a model of mental health intervention developed by an NGO called Basic Needs, and it is a model of partnership between Basic Needs and local stakeholders, local agencies, including the healthcare system. It's been tried in 11 countries. What Victoria did in her study was evaluate it in Kenya. Now, what she found was this intervention was effective, it looked cost-effective, it looked affordable, but it only really looked affordable if the NGO continued to support it. And so the challenge we have in low and middle income countries is finding these interventions which are effective and cost effective and which are sustainable within that local context. And that's where I think Emiliano's points are particularly apposite about the difficulty of translation of evidence. Now, notwithstanding what I've just said, let me just summarise from a paper from Dan Chisholm again and Chisholm Saxena, who heads mental health at WHO. This is in the British Medical Journal 2 years ago. And what they argue is that for $3 to $4 per head of population per year, they argue you can deliver an affordable and cost-effective package of mental health care. Now, it's pretty basic mental health care, but that's their argument on the basis of the evidence that's there. So possibly it's sustainable, possibly it's affordable. Thirdly, and very quickly now, economic growth. We know that many things contribute to economic growth, including health and including mental health, but we don't necessarily know what the impact is of mental health on growth and development. So here are summaries from 2 reviews. This is a systematic review by Kricklund and others in The Lancet 3 years ago now. This was looking at 2 things. It was a link from mental health to poverty and a link from poverty to mental health. And what that review concluded was that mental health interventions do improve the economic outcomes for individuals. They do help people to get out of poverty in some cases. On the other hand, the mental health impact of poverty alleviation programs is inconclusive. We don't know that dealing with poverty more generally will necessarily improve mental health. The second review, not systematic, more a rapid review by Michel Funk and others, is showing that, again, there is evidence that improving mental health can have some economic benefits and can contribute to better economic growth through its contributions to education, to employment, and various other routes. So there is an economic growth case for mental health. On equity grounds, as Emiliano showed, there is a big problem with equity and stigma and discrimination for people with mental health needs. Let me just show you one result from, this is again from the UK, but I think it illustrates the challenge that we face. Now, some of you will have come across these concentration indices, these measures of inequality, and when you do this, you look at everybody in the population, you order them by their level of income or their level of economic well-being, which you do on the horizontal axis, and then you order them by their mental health or their health need on the vertical axis. Now, that 45-degree line that's through there, the black line, if we have that line, we have perfect equality or equity. Okay, so there is no relationship between your income level and your risk of having, in this case, a mental health problem. Curves above the line show you that there is income-related inequality. And this is a study that I was involved with. What we found was that in the UK, there was very high level of income-related inequality. So mental health problems were much more common in low-income groups. And what we also found, these are the measures of inequality, minus 0.08 is actually quite unequal in various ways. This is the result for the UK for general health. And so what we can see is there is a huge difference in the level of inequality between mental health and general health. So yes, we know that health or poor health is unequally distributed, but mental health is particularly poorly distributed. So again, tackling mental health will help to address the equity issues. And then finally, two things I put together there, the socio-cultural influences and the political influence. Let me just focus on this issue of stigma. And I'm just going to show you a slide again. I showed my course group yesterday from a study that we finished and published just very recently, looking at the 27 countries of the EU. And what we looked at was the level of employment or unemployment in the population. And you've got two lines on that graph that show you the change between 2006 and 2010. In the blue line at the bottom, people without mental health problems. The brown line at the top, people with mental health problems. So you can see, first of all, that people with mental health problems are more likely to be unemployed. And secondly, over the course of the recession in Europe, that gap between the two groups widened. So mental health group disadvantaged relative to others. But what we also found was that in countries with high levels of stigma about mental illness, that gap increased even more. So being mentally ill is not good. Being mentally ill during a recession is even worse. Being mentally ill during a recession in a country with negative attitudes to mental health is the worst possible combination. And I'm going to stop there. Thank you very much.
So I made a totally different approach. It's about global child health. So I think I'm glad until now I haven't heard anything mentioned about children. So I think we cover our topic very well. So my topic including in general child health, not just the child mental health. So I will start with about what kind of global health problem in children are we talking about? If you look at the global health problem in children, what comes to your mind? So I think on one hand, in a developed country, we are fighting about obesity, right? Everybody agreed. We are fighting about substance use. But another part of the world, we are fighting about malnutrition, children's survival, the first year of their life. So how can this issue to be global when we are living in the same earth, but we are fighting totally different problems in developed country and developing country? First, I show you this infant mortality rate. This is the most well-used indicator in public health to show whether this country, the health status. I think you probably learned that in your basic public health course. If you look at that, the good news is this from the early 1990s, 50s, that is high. From all different countries like Africa, Asian, and Latin America. So through these 40 years, we are trying to reduce infant mortality rate, and it works. However, the gap is still huge. There are countries, if you look at that very dark, in Africa, in South Asia, our infant mortality rate is still like 160 to 185 per 1,000 births. But compared to that, most of the developed countries, like in Europe, the infant mortality rate is about 2 to 4 per 1,000 births. Still huge differences. And if you look at this, the infant mortality rate, I like this graph because this is America. It's showing that compared to other developed countries, America now ranking number 30 in the world, infant mortality rate. And the main reason is because the inequality. If you look at that, the black here, this is non-Hispanic black, huge rate. This is like developing country, sorry. And here, if you look at that, the white or the Hispanic is very low. This is like a normal developed country. So this is one country, but it's like totally different world. So there are huge gap exists even in a country. And so this is global prevalence of the trend of the overweight. Now we look at different problem. And through the years, as you can see that for the children, we're talking about the overweight. This is preschool children, less than 6 years old, and it's already up to, this prediction 2020 will be more than 10%. Children less than 60 years old are considered overweight. But on the other hand, in the developed country, here is Africa. You look at that, almost 30–40% of the children suffer undernutrition, not enough to eat, and try to survive for their first year of their life. So this is also to show you the graph. As you can see that the dark one is more than 30%. It's in the Africa, South Asia country, and then North America here is about less than 10%. This is underweight. So here is global cause of under 5 deaths in 2010. It means children under 5 years old. And this is also the well-known indicator for a country's public health status. And as you can see, we are now still fighting for the infectious disease after so many years of working, improving medicine, but still now pneumonia here, so pneumonia-related disease is still the highest cause of death for children under 5 years old. And if you look at that, through some kind of synergy with different source of data, and it shows that infectious disease, the synergy with infectious disease, undernutrition causes 35% of children's deaths. So that means the data that I just showed you that 35% of those deaths are related to undernutrition in the developing countries. And this is the estimate that globally, 7.6 million deaths in children under 5 years old. That's the estimation of 2010. However, it's not distributed equally. First is look at the cause. Most are because pneumonia, then it's diarrhea. But if you look at that further, those deaths happen 73% in Africa. So in the developed country, we are not fighting about the children mortality anymore. We are fighting about chronic disease. However, in countries like Africa, in the South Asia, we are still fighting about infectious disease and trying to survive in the first year and the first 5 years of their life. So this is about the child health. Then I'm going into the mental health problem. If you think this is already bad, and wait until you see that the mental health in children. First, why pediatricians is concerned about mental health problems? Because before, Emiliano already talked about they're short of manpower in the mental health workers, as you mentioned. So later, I will show you a slide about the physician intensity per children. So this is published in 1993 in the Journal of Pediatrician. It talks about that a new term called new mobility. And what is new mobility? It is the advocate from pediatrician that to define the role of pediatrician in providing increased attention to the prevention, early detection, and the management of various behavior, development, and the social functioning problems encountered in pediatric practice. Because I think a lot of countries did not even have a child psychiatrist, or this term did not even exist in many countries. So many pediatricians had to deal with the problem for the children, mental health problem. And so what kind of new mobility? You know, as before Emiliano also showed this graph, you know, that the mental health problem is multi-leveled. It had to be considered within the family and society, culture, and the country. So now this new mobility, we are talking about school problems, we are talking about children's adolescent mood anxiety disorder is increasing. Also, alarming increase in adolescent suicide and homicide, and school violence, drug, alcohol abuse, HIV, the problem of media on violence, obesity, and the sexual activity. This is a problem in developed countries. This is called this new mobility, related to the family and related in the school. And this is published last year. As you can see, now Switzerland is the highest physician, right? 45 per 100,000 population. This number is impressive. However, there's always a however. Even the second and the third is still like half. We have 45 per 100,000. But we had this discussion last week. Actually, this number is a little bit misleading because this only exists in Switzerland, part-time, percent working. I think almost no woman in Switzerland is working 100%. Maybe I'm a little bit over statement, but this number so when we look at the number, we have to be careful. This number did not consider the percentage because especially women are more likely to be in psychiatry, working as a psychiatrist or child psychiatrist. And most of them did not work 100%, or we should say almost all of them. That's why I think if we adjust for that, I think the number will come probably close to this 20-something, I think. And this is general psychiatrists all. But if you just think about this, 45 per 100,000 population is considered high. But if you look at the other country, like Mexico, 1.18, but there are a lot of countries not even included. I think there are countries did not even have child psychiatrists, as I understand. So even Switzerland has the highest number, impressive number, but it's still not enough. It is estimated from the last year's report, 2/3 of people with mental health problems are not treated in Switzerland. And this is the highest psychiatrist intensity in the world. So it's also, there's a problem of distribution. So I show you this. I think Shara will like this slide. This was published in February in the newspaper in German, but it says psychiatrists like Basel. So if you think that Sweden is high, but if you look at the Basel city, has the highest number of psychiatrists per 100,000, probably in the world. And we did this calculation ourselves, look at only the child psychiatrist, because most of the numbers combined with adult psychiatrists. But this is just the child psychiatrist. And if you look at that, Basel, probably the smallest canton in Switzerland, has the, 109 child psychiatrists per 100,000. But here, you look at those. There are 5 cantons, 0, no child psychiatrist. So there are huge difference between, this is more city canton, this is more country canton. So they are not just a problem of not enough, they are a problem of distribution. And this is the number of pediatricians. So just to say that Basel still have the highest, 243 per 100,000 children. But if you look at the other canton, like this Anteile, is 0. So this also made me to think about looking at the data. I don't have time to show it now. If you look at the data about high prevalence, or the seen psychiatrists are using service, doesn't mean they have more problem. Mean they have probably more child psychiatrists or more pediatricians. So when we interpret the data, we have to be very careful. But there is actually no data available to show that. So here, this is from my advisor that he talked about. Child psychiatry has managed to survive as a stepchild of general psychiatry. and a cousin of pediatrics, while epidemiology has steadily matured as the exact and basic science of social medicine and public health. He's mentioned that, the same time, early 1970s, when the epidemiology started to grow, like child psychiatry. But epidemiology grows nicely, but child psychiatry is still a very neglected area. And this is just to give a magnitude. We don't have a data about the prevalence of child mental disorder. And this is probably the first one in the world showing the national data. And actually, this is from the same study that Emiliano just showed, but this adult, that's shown in 2000, 20 or 15 years later, finally, we have the children's data. And as you can see, this is a 12-month prevalence rate for the children 8 to 15 years old. More than 10% of children already suffered mental disorder. And this is a lifetime. If you look at that, the number is also very impressive. These are 13 to 18 years old, and 46% already reported lifetime prevalence. So here, just to show that, to respond to Martin just said that we need to start early because most of the disease start early. This is the age of onset, cumulative age of onset. If you look at this, this is anxiety disorder. It starts very early already. It's grow. So until 18 years old, so about 40% already reported anxiety disorder. And if you look at the other, like substance use start a bit later, but this is like a behavior problem also start early. So if we want to do the intervention, we have to start early. And this is just a slide to show the, in German, sorry, but this is the Ritalin. We don't have the data on that, and we are not allowed to publish before they show it to the government. This is to show the Ritalin increased use of Ritalin in Switzerland. And if you look at this table, here, the increase mostly about from 2006 to 2009 only, and I believe now it's even higher. And here, mainly about 7 to 18 years old boys are the highest user of Ritalin in Switzerland, and this is boy and the other side is girl. However, this study also showed that, I don't have a table now, but I can tell you now, most of the Ritalin are not prescribed by child psychiatrists. Some by pediatricians, some even by apotheke. So they are taking this medicine but without getting any service or treatment. So to come to the issue of child mental health, I think, as Martin just mentioned, that we should start early, right? As I showed before, a lot of mental illness start early in the life. So right now, in Switzerland, the depression has become a single most frequent reason to receive disability social welfare. So if we don't start early to treat them, later we are paying the EFAL, right, disability welfare. So it's better to invest earlier than later. And another thing is, so my key point is to advocate for children. We need to invest on children and to start early and to close the gap between the city and the countryside. It is not just the issue of not enough, it is also the issue of distribution. The country and the city, there are huge difference. Why Basel has so high? Because Basel is a canton which are a city canton. But compared with other canton, a lot of places did not even have a child psychiatrist. And also lack of data. As I mentioned, we just have this until now, there is no national data on the prevalence of child mental illness in Switzerland, also in many other countries. The only one that I just showed is just published 2 years ago in America. And also there is lack of the healthcare utilization data. Because if you just get the data by the hospital statistics, then there are places the children are not treated, or they don't even know they have this problem to be treated. So the data is biased. But until now, we don't have a valid data on that. And talking about child mental illness, the big difference from the adult psychiatry is children still depends on the parent. So there's informant issues. Where do you get the information? So a lot of time, the problem is the reflection of the family problem or the maternal depression, or the mother who has a mental illness are more likely to report their children have mental illness. Sometimes it's a reflection of the parents' bias. And so it is well known that when we're talking about the child mental health, we need to consider source of informant. Because children under 6, you cannot get the information directly from the children. So there are issues, and they have mother, father, teacher, clinician, and subject themselves. So children behave differently. Sometimes they behave well in school, but they behave totally different at home. So there are issues of assessment. The correlation between the informant is about 0.3. This is very common, the very low correlation between informant. So how do you really get a valid diagnosis? And so agreement also vary by the illness symptoms, by their age, by their gender, and by their family status. So I will stop here, and there are some issues we can discuss later.
We are on time to open up the floor and to collect maybe a first round of 3-4 questions, and then we try to answer them.
Thank you very much. It was very interesting. It gives us a whole picture. We saw that the main problems are by adolescents and more in the part of the poor society. So my question is, what about education in this problem? We get the children a lot of technical education, but afterwards, I mean, there are some difficult to handle what the society expects from them. So my question is, what's about the education in this point?
Thank you very much. First of all, I want to thank all the presenters for their presentations, and I have 3 brief questions. To Professor Emiliano Albanese, I much appreciated you linking the whole picture also with the human rights framework and going a little bit into the direction of the international scene. Could you please comment on how you see the integration of mental health issues into the post-2015 development agenda? I know that there have been attempts made to integrate it into the NCD agenda with all that it carries with it, all the conflicts of interest and the issues around the different actors involved in that agenda. But I don't think this has happened as a firm sort of implanting of mental health into the global action plan. So if you could comment on it and say how you see sort of the future in that area. On the second presenter, could you please say what is understood under the basic package that is being proposed for the $3 to $4 for the basic mental health care delivery? And for the third presenter, I was a bit disturbed when you were saying there is, the question of the third and first world. My understanding is that there is now the discourse shift towards double burden of disease, that we are seeing actually the same disorder that we, let me put it this way, that we see undernutrition and overnutrition in both parts of the world, if we so roughly and politically incorrectly, I suppose, divide the world. And also we see the manifestation of both phenomena often in the same family. So also, if we talk about malnutrition, I think we have to look also at the questions of, for example, micronutrient deficiencies, which you would still classify, of course, as malnutrition, not necessarily in terms of weight gain or weight loss. So there I had a difficulty following your argumentation. And I also wasn't quite sure how to reconcile the problem of when you were presenting, especially the call for, if I understood correctly, increased number of psychiatrists while listening to the first presenter and listening to the Brazilian model. My feeling was that the sort of psychiatric care there was a shift again in paradigm, how you would treat and how you would address these issues. And I was wondering, finally, you didn't elaborate at all on the sort of basic determinants why we are seeing the increase of the mental disorders, and the increase of Ritalin, I think, in the Switzerland is a very alarming signal. Thank you.
I think we answer and then make a second round. So.
Okay, so I'll start first, alphabetical order. So I think that the occasional point is great, but and it's clearly a complicated discussion. But I believe that the latest report that is also published in conjunction with the WHO about the social determinants of mental health is enlightening in that regard, because it covers particularly what happens in early life and all the vicious cycle. So when we say psychosocial intervention, school is one partner in a sort of a network where family, the community are all involved. We talk a lot about the determinants, but they also talk a lot about what interventions work. And those that are most effective are those that in fact encompasses all aspects of society from a very broad point of view. Going to your question, I think that is a good point. I put it very simple. I think that the progression has been from a discourse about the violations of human rights with very disturbing images, which has worked somehow. We are now, and this is very good, to a legislation stage of this discourse. What does that mean? That we now have enforced international laws to which countries are bound that provide resources, not just to claim rights to be respected, but also to design public health mental plan. And the WHO, less than 1 year ago, actually detailed an action plan as an official document of the United Nations. So the second phase, I believe, is the constructive one, is propositive, and is therefore more complicated. You're right, the integration into chronic diseases may cause some troubles and comparative allocation of resources, but I believe that the legislation bit and associating with other disabilities has been very, very important for mental disorders, because we don't have to forget that the stigma and discrimination prevent a lot of the actions also in a propositive way.
Okay, let me just start with the second question first, and I'll come on to the education one. I mean, in this basic package, I haven't got my slides in front of me, so I haven't got the crib sheet, but in this basic package, what they evaluated, what they did was to pull together evidence from other studies, and the basic package includes what we call basic medications that are beyond their patent period, that are low cost. In fact, in mental health, there haven't been very many changes in pharmaceutical development for many years now, so what is outside patent is probably just as good as what is inside patent. You know, they're basic medications for depression, for psychosis, very basic psychosocial, because you can't devote huge resources to training clinical psychologists, so you've got to have something which is very straightforward. And it's basic advice, particularly around alcohol misuse. And basic advice can be very effective. So it is a very, you know, very bottom level package, but actually can be quite effective. On the education question, I think I'm really pleased you asked that question. I think education is so important in this area. I'll just mention sort of three things there. One is we did some work published recently looking at the costs of child and adolescent mental health problems, and the cost in the education sector is much greater than in the health sector. So these are regular teachers and special teachers supporting children with emotional behavioural problems, and they make a bigger contribution in resource terms than does the health sector. Secondly, that education is one of the very few almost universal services we have. In our countries, most of our countries, it will be universal. In low and middle income countries, it's becoming more universal. So the opportunity for doing something in the education setting is really powerful. Two quick examples of studies. One is on teaching anti-bullying or bullying awareness and dealing with bullying in schools. And the other is teaching social and emotional learning. And the evidence from a number of countries now is that if you teach that in school settings, you will have benefits for many years to come. So I think there are things we can do to help to build resilience in that setting. And then the final thing to say on that is some research published last month from colleagues at the Institute of Psychiatry showed that children who've been bullied at school still had psychiatric problems 50 years later. So the links across the life course are very, very important. So doing something in school, I think, is really important.
Okay, so I will just address this question about this different world. I think I try to exaggerate a little bit just to think, when we talk about the global health, and I think we should really try to close the gap. But it's from the number you see that, for example, the 7.6 million children under 5 died in 2010, and almost 6 million happened in Africa and South Asia countries, and the others, all the other countries. So for those countries, they are still fighting for the quality of water, the hygiene, the survival in the first 5 years, or even the first years. So, and I think this is less really for Europe. But in America, for example, in one country, this can also happen. Like, as you see that the inner city, American, the Black, those areas, the infant mortality rate is as high as in any developed country. So it's so divided just in one country. But I think in Europe, as you can see, most of the country, if you look at the data, the first 20 even, the lowest infant mortality rates have in Europe between 2 to 4. And so, but if you look at the developing country, there are more than 100 per person. So it's really a huge difference. That's number one. And number two, about the mental health increase. I think it's difficult to talk about increasing because there's no data to show the trend about child mental health. But about the Ritalin use increase in Switzerland, it's going to publish soon in September, and they will go to the government. So that's why I'm not allowed to say much before they release this report in September. My understanding is, because I also did a survey, a national survey for the children with special health care needs, and my person is surprised to see that a lot of children reported they are depending on drugs. Most are the Ritalin, using more than 1 year, but they never see psychiatrists. So, and that report is going to show where they got their medicine from. So there is a lack of a child psychiatrist or the therapist. And this is not contradict to Emiliano's direction data. I think he's trying to show to reduce the hospital bed. It's like inpatient, but we need more outpatient. That's why now there's a movement actually just published this month that in pediatrics, it's like advocate to have the pediatrician and the psychiatrist work together, because a lot of people have no access to psychiatrists, so their first role. So I think now it's the movement to integrate social worker, to integrate pediatrician, even general physician, because a lot of countries did not even have psychiatrists. So those are the direction for the country which has a low amount of psychiatry. They need to go and need to work together. So I don't know whether that answered your question. Probably still not satisfied, but okay.
I suggest we do a second round of
questions. So here, Marisa is coming here in the front.
Thank you. So my name is Judith Richter, and I have a kind of dual qualification. I started out as a pharmacist, but in the current of my life got so worried about the close links between pharmaceutical industry, health professionals, and the institutions that are meant to work in the interest of people, including the World Health Organization, that I ended up gaining a PhD in social science and now dabbling in conflict of interests, and having learned a lot from Professor Rodwin, whom you heard yesterday, but also from Dennis Thompson, who worked on conflicts of interest and tried to help physicians cope with the issue. So when I also, in the current of my life, went away from the physician-centered model of medicine towards the more social model of medicine. And therefore, my remarks would be two. One is to Dr. Mohler-Kuo. As a health professional, I have worked as a pharmacist in Switzerland. Pharmacists can in no way dispense or prescribe Ritalin. It is highly classified. It's classified in the same category as morphine. We need a prescription which is for stupefactions. So pharmacists have nothing to do with the increase in Ritalin. But how much does the overly close link between physicians, medical universities, and pharmaceutical industry to do, first of all, with how this problem is defined? It is true that people say children are more excited, not concentrated enough for school, kill children in the United States in schools. But is the solution more Ritalin and more psychiatrists? So that would be my first question, actually. And this is a first world problem which has a lot to do with arms industry and overly close links with industries also. The second question was, I would like to quote very briefly the definition which Dennis Thompson has developed for physicians, which is most widely used, and add to it, into it, a definition which was created in 2009 by the Institute of Medicine, because they were so worried that people tried to now cope with conflicts of interest at their own level of an individual, when the institutions have so many conflicts of interest that an individual can be as ethical as they want to. They cannot anymore work in an ethical way. So he says, a conflict of interest is a set of conditions in which professional and institutional judgment concerning a primary interest, which is your ethical mandate, tends to be unduly influenced by a secondary interest, which for most people and institutions are financial interests. We all need to live. Institutions and academics and WHO needs money for their work. And there I maybe would like to come to Professor Knapp. Whenever I hear the word public-private partnerships, I have like antenna going up. The Americans would say code red. Are these not overly, I would like to have a definition really of this public-private partnership, because in most current cases, it simply means you have, in the health arena, an arrangement where you invite the industry in. You also call a partnership to take money from them, so you change a bit the terminology, and do invite them to be in decision-making processes where, if you think along the spirit of conflicts of interest, which is to protect physicians, health professionals, officials, and institutions from being influenced by financial interests, they usually say don't invite industry into public processes so that the public actors and academics can reflect genuinely in the interest of people. So I would like to know, when you are using the term public-private partnership, here concretely, what is it? But at the WHO at this time, what we are trying to do, or what people are trying to do, is to disentangle overly close relationships. And so the question is also for physicians. In the old times, one simply said, just say no to corporate money when you do your work.
Thank you. Maybe if there are other questions, we can then at the end. I think it's the last chance to take the microphone during this summer school, because it's the last plenary session. If it's not the case, I hand over the floor to one of the speakers.
I can respond on the public-private partnership. I mean, firstly, private is anything. Private is often a phrase used for anything which is non-public. So in the basic needs model, for example, public-private partnership would refer to the links between public sector agencies, shall we say, in Kenya, in the case that the example I gave, and the NGO Basic Needs, which is a UK headquartered NGO, but has partners in 11 countries. So I think my general position would be that we can all think of plenty of examples of the private sector behaving inappropriately in public-private partnerships. But I think we can also think of plenty of examples of the public sector behaving inefficiently, fraudulently, inappropriately, unfairly, and so on. And I think what we've got to find is the right blend between the public and private. And in private, I mean the whole range of non-public collective bodies. So I think I absolutely agree, the danger of conflict is there, but we need to work transparently to get the best out of all those different partners, I think.
Okay, first about this Ritalin issue, I think this is a very sensitive issue right now, and I didn't mean that, maybe I can misleading, but I didn't mean that the pharmacists are prescribing those drugs. No, I don't mean that. What I really mean is that a lot of children, they probably got the prescription from their doctors, not necessarily psychiatrists, not even a pediatrician, but they continue to just maybe they don't follow up to go back to see, or that they don't have any therapy, and they're just taking this medicine. So that's a more concern, the issue right now. And I think this increasing of Ritalin use is, there's no survey about it, but what we got is from the insurance data, because they had to pay for it, so they have the data to show whether this amount of prescription is increasing, and we did show that. So I hope that answers your question. And I think this is a worry about this industry, with our fields. It's unavoidable, but how can we? I think it takes really a lot from the government, from the physician himself, to prevent the situation getting worse. And also, I think the public education, that people shouldn't think that this is some kind of drug one can just take it without any side effect. So I think this is, in America, is really an extremely huge problem. I have data to show the difference between these two countries. In America, it's like 14%, and in Switzerland, my data 2010 showing about 6%. So I hope that right now Switzerland still much better compared with America, and I hope the situation is not getting worse.
Well, I'm not sure whether any of your comments were addressed specifically to me, but I think that Martin raised a good point, because if you think back, well, you showed you several slides, but the idea that private sector is also, for instance, TPO, the famous Dutch NGO in mental health, that invested in Burundi, as I showed you a picture of the motorcycle or psychosocial workers. Well, that was an entirely private initiative, and it was above and beyond any global dimension or convincement. But the money, indeed, were coming from donors of any kind. And to be honest, tracking back what the funding of TPO is sometimes complicated. But if you judge programs, because everybody has conflicts, and it's just not a financial and economic types of conflicts, probably we should simply have have a bigger table, so that everybody with different conflicts is sitting around the same table, and we come to a compromise amongst all these conflicts. The idea that we can act without conflicts in the first person, I think is too idealistic. The problem probably is that in psychiatry, conflict of interest may be ideological, and that the prominent role of psychiatrists from a public health perspective has halted the reform because of the biomedical definition of psychiatry, which clearly doesn't fit with what we have. But psychiatrists, of course, make resistance to admit that they are no longer only or mainly part of the medical world. So let bring more people with different views to this table, and it's exactly the task of public health, and I believe the fact that none of us is a psychiatrist, to some extent, would prove what I'm saying.
So thank you so much for, I think, this very nice session. I would like to conclude with some wrapping up some points. I think I got confirmed that mental health is a very important issue, to continue to do research on that, to invest public money. And my personal take-home message, since I have, as I told you, the chance to chair now a school with nursing education, social worker, and economist, the message of integration. So we need to work together from different perspectives to face this important problem. And finally, I would like to thank you also for attending, not only for attending, but also for engaging in these debates, because I am convinced that knowledge is every time distributed among the people. And so it is a co-production that we had here in these days. It's a co-production of an experience, of knowledge, of mutual learning, as Marcel Tanner used to say. The last word is for Emiliano, who, without conflict of interest, is proposing you an initiative to be trained in the topic of mental health. So please.
Yeah, this is an SSPH Plus, also co-funded initiative, and it's a reality. So it will be running for a second round, and you have the privilege to have Dr. Natasha Palmont. There she is. Who's attending one of the courses here, and not the public mental health one, clearly. And there are brochures out there. So this is an opportunity to actually link up, and is really part of the educational offer of SSPH Plus. And I must stress the point that all the things that we approach here are covered in this, and the CAS program, well, Swiss people are very familiar with this, are highly compatible with your work environment, because the idea is really that it's not just postgrad activities, but that your projects, your issues and problems related to public mental health should be brought into the CAS and hopefully resolved.
So even in the last session, we are very Swiss, so it is time for the coffee break, and enjoy the day.